and they are going to be sharing information with us about the Idaho State Long-Term Care Ombudsman program. I'm just going to take a brief moment to read each of their bios and turn it over to them. Prior to moving to Idaho in December of 2022, Fanny worked in healthcare for over 25 years. Most has been spent in long-term care. She was a nursing home administrator for 10 years, operating nursing facilities. And her career in healthcare has blessed her with the opportunities to work in hospital operations, hospital case management, and contracting. And prior to becoming a state long-term care ombudsman, she was overseeing the care of patients post-acute with a team of physicians and case managers. As a lifelong learner, she obtained her master's in industrial organization psychology in 2018. And during her tenure as an administrator, Fanny served on boards such as the Hispanic Chamber of Commerce, Kiwanis, and the Lions Club. She also served the community as a CASA, a CASA volunteer, and that is a court-appointed special advocate. And then Stephanie Persinger. Stephanie is the Ombudsman Program Manager with the Southwest Area Agency on Aging. She loves her job as an ombudsman. She enjoys working with the residents in assisted living and skilled nursing facilities and assisting them to resolve any problems that they may have. She is passionate about advocacy and the rights of residents, and she's been an ombudsman for almost 12 years. Fanny and Stephanie, thank you for being here today and for supporting the Learn mission, vision, and purpose and sharing your time and expertise. And thank you for the work that you do and your teams do on behalf of the residents and their families, as well as the representatives at the skilled nursing facilities and assisted living communities where they reside and where you have oversight of. So at this point, I'm going to turn it over to Fanny to kick things off.
Thank you, Mary. That was such a nice introduction. And thank you for allowing us some time today to talk about the work we do in our program. We appreciate everything that you do as well. So thank you for this time. I'm showing my screen, right? I'm the one, yeah.
Yes, we did see it, now it went away.
Oh.
So I had presented. Do you want to present and drive your slides? That's fine, if you prefer.
No, you can do it, that's fine.
Okay.
Okay.
Just say advanced screen when you're ready.
All right, we see it.
Great. For some reason, I can't see it that well. Okay, I see it now. Thank you. Okay, so yeah, I'm the state ombudsman for Idaho. I'm actually new to the program. I just started in April, like Mary said. So we're gonna give you a little overview today of what we do in our program. So you can go ahead and advance the slide. So today we're gonna give you an overview about what the program is, about our volunteer program. We're gonna also talk about residents' rights, and how to access the Ombudsman program, how anyone can access it. Next slide. So the Ombudsman, what is the word? So sometimes people are saying, Ombuds, what? How do you even say that word? So Ombudsman, it's a Swedish word, and it's pronounced Ombudsman, and it's a specially trained advocate who's given authority under federal and state law to investigate and resolve complaints made by or on behalf of long-term care consumers. I believe the military also uses ombudsmen to communicate between the officers and the family members, if I'm not mistaken. So next slide, please. So this is just a little history. Fun fact, in 1974, Idaho was one of the first 9 states to pilot the program. 1978, ombudsman regulations were added to the Older Americans Act. In 1978, also, all states were required to operate a nursing home ombudsman program. And then 1981, the program transitioned to change its name to Long-Term Care Ombudsman Program due to expanded responsibilities. We not only go to long-term care facilities, we go to nursing facilities, assisted living facilities, and community home-based programs as well. Next slide. So we get our authority. It's a federal program. We operate within the Idaho Commission on Aging, and we get our authority from the Federal Older Americans Act, Title VII and Title III. We do contract with 6 AAA agencies throughout the state. So those agencies, they actually hire and do all the onboarding for the ombudsman, and I actually oversee the program. So we work together in that way. The local programs are an extension of the state long-term care ombudsman program. I work really well with all the directors. Like I said, we have 6 areas that cover the entire state. And we have a total of about 15 ombudsmen, and we also operate with volunteers. Right now, currently, we have 10 volunteers. Before COVID, the ombudsman program had over 50 volunteers, so that's an area that we're rebuilding. And you'll see further how you can get involved. So like I said, the AAAs, they do the hiring, the onboarding, and as a state ombudsman, I do provide the direction and the training and assistance for all the local ombudsmen for the program. Next slide. So what's our function and scope? We provide advocacy to ensure residents receive the adequate health, that they feel safe, and that they feel comfortable in their new home or short stay if they're in a nursing facility. We ensure that residents have regular, timely, and private impeded access to the services provided by the Ombudsman program. We do routine visits and also visits that are not, I won't say surprise, but they're not scheduled visits to the facilities to check on how the residents are doing. And then we also respond to complaints or phone calls. We share information on available resources to assist residents in obtaining needed services and support. So we do, part of our program it's a requirement to offer education and training and resources to our residents and their families and the community as well, like this program today. When we are working with residents, we identify, investigate, and resolve complaints made on or by the residents or by their representatives to the satisfaction of the resident. As I stated, we are resident driven. And so any action we take is taken based on what the resident's directive is to us. For example, if they have a complaint and they tell us, well, we don't want you to do anything at this time, then there's no further action that we can take. We do try to encourage the resident to allow us to advocate for them, but if at the end of the day they say no, then there's nothing more we can do. But we do follow up with them to see how they're doing and see if they've changed their mind about allowing us to advocate for them. We investigate complaints, and again, related to action or inactions or decisions that may adversely affect their health or safety, welfare, or rights of residents. Sometimes facilities can make decisions that affect the residents, but sometimes they may not be able to speak up about it. So that's where we come in to help them express their voice. And we do try to encourage self-advocacy, because we want the residents to feel empowered and not have one more person telling them what's best for them or what they should and shouldn't do. We also, like I said, part of the requirement of the Ombudsman program is to provide education. And so we do provide education on various topics to our residents, our family members, and the community. Next slide. And these are just some of the topics that we provide training on. Of course, the Ombudsman program, mandated reporter. The Ombudsman is not a mandated reporter. A lot of residents and family members and agencies think that we are, but we're actually not. And the reason is because it is a federal program that was created to protect the resident and make them feel safe. And so they need to feel like confident that they can trust us, and we are going to be that one person that is not a mandated report. It's not gonna go and do anything without their consent. Sometimes we get phone calls from staff from the facility wanting us to report things, but we do educate them and say, you're actually a mandated reporter. It's your duty to report this. So we do train on mandated reporter, what it is and what it's not, and how we are not. However, as the state ombudsman, I do have the authority to report to authorities if we actually see that a resident is being harmed, and even if they don't want to speak up. So I do have that some leeway with that. We do provide education on resident rights, on scam prevention, dignity and respect, advanced directives, neglect, abuse, and exploitation, dementia skills, admission agreements, and our volunteer program, of course. Next slide. And these are some of the other supports that we provide. We do make recommendations to make changes in laws for our residents in long-term care. I put their senior issues, but it's specific to long-term care residents. We also provide assistance in developing of resident and family councils. Most facilities do have a resident council. Some don't, and we do encourage the residents to have a resident council and a resident council president, because that's their opportunity to get together and express their concerns and talk about the things that are going to make them feel more comfortable in their own home. So we do assist with that. We do attend resident council meetings as well by invitation of the resident. So if the resident does not invite us, we do not attend. And then also family councils. Currently, there's not very many family councils in Idaho. And so the long-term care ombudsman program we are starting a family council program, which we're hoping to launch next year. And it's going to be a platform used for our residents to educate and provide resources to family members to families that have loved ones in long-term care. So we're actually working on that now. We also encourage and work with the facilities to start their own. So, well, we are working on launching our own as well. We do make quarterly visits to the facilities. And like I said, we participate in resident council. It's actually a requirement that every ombudsman visits every facility at least quarterly. So we do provide, again, resources to resolve resident issues. We work with leadership. We brainstorm with them. We really see the facility leadership as a partner, and we have a good rapport with them, as well as like other agencies like from health and welfare, because we're all in this together, and we really try to help the resident to live their best life in long-term care. And then we act as an impartial party to provide the platform for resolving issues. Next slide. How do you access to the ombudsman? See a question in the chat. Can I answer it a little bit later, or do I keep going? Do you want me to answer it now?
You can answer it whenever you like. Yeah.
Okay, I can answer it now. So we are actually gonna use the platform of Zoom and Facebook. We started a Facebook group, a private group for family members, and we're gonna use Zoom to do monthly meetings and trainings with them. So my vision is to have different speakers from different areas of expertise that can offer resources to family members that they find valuable. Like a lot of, we get a lot of questions about like power of attorneys, guardianships, and that kind of thing. So I would like to have someone talk about that. So retaliation in a nursing facility, resident rights, how families can get involved. So we're just going to provide like a wealth of information. That's our goal and our vision to our family members, so they're better equipped to advocate for their loved ones as well, and they have some knowledge. So I hope that answers your question. Let's see. So we do want to make sure we're providing equal access to anyone throughout the state of Idaho. So anyone can access the ombudsman. You can contact us via email or telephone, in person, or any AAA. You can go into any AAA and they can provide you information on how to contact the ombudsman. And also the calls can be made anonymous, or you can identify yourself. So, you know, it's your choice. So anyone that has a concern regarding a resident of a facility can reach out to the ombudsman. A residents call, family members. We also get calls from agencies or hospitals or a member in the community, or like I said, the staff call. And the only thing is we can only advocate when the resident is actually in the facility. Sometimes we do get calls when the resident has left, and then the families, you know, has all these grievances, and then they'll call, or the resident, so they'll call us. Unfortunately, once they've left the facility, we can no longer help, but we do refer them to other agencies that can help. So that I just want to make sure I mention that. We do have 5 days to initiate an investigation unless it's urgent or resident is at harm, then we will respond within 24 hours. Next slide. So this is our investigation process. Once we receive a call, we initiate contact with the resident. Because again, we're resident driven. So we go first to the resident. Sometimes we may get a concern from the family, but the resident may not have the same concern or not have any concerns at all. So then there's nothing further we can do. So we always start with the resident. We either make a phone call or we go in person to talk to them and see what they can tell us about the complaint. So we always, when we receive a complaint, the first step is to go to the resident to validate it. Because we do want to empower the resident to advocate for themselves. We do need, again, resident consent to take action. We also identify which resident's rights was violated to tie it to the IDAPA rule or federal law, because we want to make sure that the resident and we tie it back to what right was violated so that we can advocate for that. We do talk about options for solutions, and we determine who's involved, if they've contacted other agencies, if they've reached out to the facility first, and where they are, or if it's the first time they bring it up. So we really try to ask a lot of questions to get the picture, the whole story of what's going on. And if other residents are affected, because again, we want to see the full story of it. We again work with facility leaders to solve the problem to the satisfaction of the resident as much as possible. And we also work with other agencies if it's appropriate and if the resident gives us consent to. What's this question? Let's see. There's a question here. Oh, that's from the main number for Southwest Area Agencies. Go to Access Specialist. We'll go directly to Fanny's program. It's 208. This is actually, yes, that is the number to the local here in this is 888-3. Yes, that's correct. Thank you. So again, once we done our investigation, we do go back to follow up with the resident and see how they're feeling, if their situation got better, and we're hoping that it did, and if not, then we'll continue to work with them. Next slide. So how's the program monitored? Again, all of our activities are resident driven. I keep saying that because that's how the program is set up. We do make unannounced quarterly visits, which is a requirement to all skilled nursing facilities and residential assisted living facilities. We do complaint investigations. We participate in resident and family council care conferences. We provide advocacy only, again, in long-term care facilities. And we do provide staff and educational trainings. And all of our data is reported to state and federal level. So, and they are monitored by Administration for Community Living. And I also monitor all of the activities of the local state ombudsman. I do have monthly meetings with them, with the entire team, and then I speak to the program managers almost every day. So a couple of times a week. So we're very great group. Like, our ombudsmen are amazing. I'm just so blessed to be able to work with them.
So Fanny, there's a question for you. If a family member or professional is making the complaint on behalf of a resident who has a cognitive impairment, will you work with family and or continue the investigation based on the reference observations? Essentially, it's how do you handle resident driven if there's a cognitive impairment?
Yeah, so we find out who is the resident, who has power of attorney for them, or who's their representative, and then we'll work with that person. If it's a family member or if they're in their guardianship, we'll work with the guardianship program. Yeah. Next slide. So we get our funding from the Older Americans Act through Section 304 D1B. And it's Title VII Ombudsman funding and Title III, Chapter 3 Abuse Prevention Fund. So that's how our program is funded. Next slide. And so this is our volunteer program. Like I said, we're always looking for volunteers. The Ombudsman volunteers are certified. They go through the same program that the hired ombudsman goes through, and I have to certify them. I check that they receive the proper training. They have to complete 36 hours of training, classroom, with a combination of classroom and field training. And once that's complete, I review all their paperwork, and if it's satisfactory to the program, then I'll give them a certification to make them an ombudsman volunteer. They identify complaints, they do rounds in the facilities, they provide information to residents about long-term care and their rights. You don't have to have any experience because we do provide a lot of training and support. So if you are interested or know someone that is, feel free to reach out to me. My contact's at the end of the presentation, or you can reach out to your local ombudsman as well. If you're interested or know someone that is. Next slide. And now I'm going to hand it over to Stephanie, who will present this part of the program.
Hey, Fanny, just real quick before Stephanie takes over, there is a question in here regarding volunteers. And that is, what is the average hours that a volunteer serves per month or week? So in other words, what's their commitment?
Yeah, really, we ask for 2 to 3 hours a month. But if you're able to give more than that, we are happy to work with you. If you can do 2 hours a week, that would be great. So there's really no minimum or maximum, but usually for the most part, they commit to 2 to 3 hours a month.
Okay, thank you.
Hi, I'm Stephanie. For some reason, the camera doesn't seem to be working. I'm not really sure why. So I guess you will just have to listen to me. You're not missing much.
And Stephanie, your audio is a little bit choppy too.
Is it? Okay. I got
That's better.
Is that better? Okay.
That's much better.
Okay, so okay. So the resident rights were started really with the nursing reform law, which was supposed to promote and protect rights for the residents that stressed individual dignity and self-determination. So that's kind of what the resident rights in the nursing home go by. So some of the resident rights in a skilled nursing facility, one of the first ones is to receive adequate and appropriate care. So that's kind of, the Nursing Reform Act was also supposed to maintain and improve quality of life for the residents while they're in there. So when a resident goes into a skilled nursing facility, they should be able to maintain their baseline, and it should be able to improve quality of life. Because a lot of times when these folks are going into a nursing home, it's because they're pretty sick and they're needing help. So a lot of times when folks go into these homes, we do see an improvement and stuff, but we want to make sure that that's happening. So that's kind of stuff we watch for during our quarterly visits or as we talk to people. They also have the right to be informed of all changes in medical condition and choose their own physician. So a lot of times, just because they're going into a facility doesn't mean that they can't still make their informed of their medical conditions, and that shouldn't be hidden from them. They also have the right to choose their own physician. The skilled nursing facilities always have their own doctor that visits all the time, but if the resident had, already had a physician in the community and they choose to keep that physician, then they are supposed to be able to do that. So they have the right to be informed of all changes, as far as like changes in rooms, and they also have the right to be communicated to in a language that they understand. They have the right to participate in their assessment and care planning, treatment and discharge. So the facility is actually supposed to do like some care planning and reassess them regularly if there's a change of condition, or I believe it's every year at least, I think every 6 months. But so the resident should be able to be in those care plans if they so choose. So we want to make sure we do get invited to care plan meetings. So sometimes when I get invited to a care plan meeting, I'm always like, well, is the resident okay if I'm there? And if the resident isn't even involved, then I really encourage the facility to, invite that resident to their own care plan meeting, because they still need to be involved in that. So they need to be able to, they also have the right to refuse medication and treatment. So I get a lot of calls sometimes on people, they're not taking their medication, but a resident has the right to refuse medication. A way to work around that might be for them to, reapproach the resident. They should have a plan on in case that happens. And they have the right to refuse treatment if they don't want to, like physical therapy or occupational therapy. They have the right to refuse. They still have all the rights that we have, that goes. So they have the right to refuse chemical and physical restraints. I mean, there should be no physical restraints in a nursing home. That is not permitted. So I get a lot of people calling, they want the rail on the side of the bed, but that's really not something that should be happening, because we've discovered that a restraint like that can cause more harm than good. They have the right to review their medical record. I always say, well, that's your record. That's the resident's records. So they, that they need to be able to review it if they're requesting it. So, so what I see that DM wrote about different rights for rehab. Really, no, it's a skilled nursing facility, so they all still have the same rights. The one thing with physical therapy, though, is that you want to make sure that, you want to really encourage it, and the facility should know how to do that, because a lot of times physical therapy can be painful, so sometimes residents don't want to do that, but the skilled nursing facility staff should know how to encourage the resident to participate in those therapies. They need to be free from charges for services covered by Medicaid or Medicare, which usually I haven't really seen that happen, too much, where they're being charged for something that's covered by Medicaid or Medicare. But they have the right to manage their own funds. So they also they also have the right to be made of what's available in services and what those services, what the fee for those services are. They have the right to privacy, like during their cares. They have the right before someone walks into their room to have them to knock on the door and to announce that they're coming in, or they have the right to private unrestricted communication with any person of their choice. They have the right to not have their personal, financial, or medical affairs talked about in the hallway, or so it's a privacy issue. I see a lot of times that people forget about that in these homes. So when we're on visits, I do try to remind them if I see that, to that's a violation of the resident's privacy. They have the right to access visitors in or outside the facility. So they have a right to have visitors of their choice visit them. They also have the right to refuse visitors if they don't want to see those visitors. So I kind of go around with that sometimes, and most of the time I can, convince the facility if they don't want to see that person, they don't have to, because just like in your own home, you don't have to, you don't have to answer your door if you don't want to. But they have a right to a 30-day discharge notice from the facility, with also the right to appeal that discharge and not be discharged while that appeal is pending. So they have the right to a safe discharge and a transfer should that happen. And in a skilled nursing facility, there's only so many reasons for a discharge or a transfer. So it's harder to discharge a person from a skilled nursing facility, I feel, than assisted living facilities. So that's kind of the skilled nursing facilities. The resident rights in the residential assisted living facilities, or the assisted livings, are written in the IDAPA rule 1603-22-550. And so there's requirements for the resident rights. Also, assisted livings are also kind of governed by landlord tenant laws. So it's different than a skilled facility. Residents in assisted living also need to be able to have access to their resident records. So if they request their records, they should be able to get those records in 2 business days. That's how it's written in the IDAPA rules. They have the right to privacy. No one opening up their mail. They have the right while they're on the phone to not have that, not be listened to. They have the right while they're meeting with family, or not to be interrupted, by a staff member coming in. They have the right to meetings with residents and family groups and their doctor, or any kind of, healthcare individual that's visiting them. And before anyone goes in their room, they should be knocking on the door and waiting for a request, and I get staffs tell me, well, sometimes that resident doesn't hear. It's like, well, all you've got to do is just peek in there and announce yourself. So I never walk into a resident's room without knocking first. They have the right to humane care and environment. So that includes a lot of things like their diet. They have the right to a healthy diet, or anything that's, if they have some like doctor orders to not eat stuff, they have the right to be able to get that diet in the facility they're in. They have a right to a safe and sanitary environment. They have the right to be treated with courtesy and respect by the staff. So that's kind of a humane care and environment covers a whole lot. So I like to tell my staff is, so you're working in this facility, but this facility is your resident's home. So you're really working in the resident's home. And so I like to see my staff, or not my staff, but the facility staff actually, think of it that way. So they have the right to dietary preferences, just like I stated, on, due to religious beliefs, not eating certain things, or allergies to food and stuff. The facility should take that into account when admitting that person and make sure that they can provide that for them. They have the right to communication in a language that they understand. So, a lot of times people get folks in there that may understand, but not as well. So if the person is, speaks a different language, they should be trying to provide an interpreter, or have it written in a language they understand so that they can read it and understand it. They have the right to refuse employment. I always kind of laugh at this one, but not all places will actually ask the resident to do a job or stuff. But in some of my smaller facilities, I have younger folks, and so a lot of times they really like doing something for the facility, but they need to be paid for that. If they, are doing that, the facility needs to be paying that. Like I have a facility that I have a guy that mows the lawn. He loves mowing the lawn, and he loves making that extra money that he gets from mowing the lawn. So, but they have a right to refuse that if they don't want to do it either. They have the right to manage their own personal funds by, so a lot of times this kind of like some facilities will want to, make them take it out of their checking account right away. So and if that's not their choice to do so, they can actually try to negotiate that so they don't have to do it. Because they should be, if they want to, they should be able to manage their own personal funds. They have the access to visitation, so anyone visiting them should be able to come in and visit, them when they wish to have that visitor. They have the freedom from abuse, which everyone in all these facilities should have freedom from abuse. And if they do have, if something like that is happening, they have the right to file a grievance or bring that to someone's attention, and they have the right to have someone promptly address that. They also have a right to control the health-related services they receive, again, by choosing their pharmacy, choosing their doctor, choosing, what therapist they're working with if they're coming into the facility. But they should have control and the right to choose any person that they want to at that. And again, they have the right to file a grievance without fear of retaliation. What I see most of the time when I'm in these places, a lot of times people don't like speaking up because they're so worried about losing their home and stuff. So we always try to really empower our residents and talk about that a lot with the residents, as well as with my staff members and my administrators about, residents should be able to complain. That's going to help you improve on your job by, making a resident happy and unafraid. That's what I would say. A happy resident is easier to take care of than an unhappy resident. So I really encourage that all. And I think, gosh, did I just fly through that? I hope if anyone has any questions, please feel free to ask.
This is Mary Millett. I actually do have a question. With you had mentioned that in terms of working with the assisted living communities as well as the skilled nursing facilities or long-term care facilities. I think you mentioned this, that you look at leadership, as your partners, right? And then also the folks who are actually working, the floors and working directly with the and with turnover, unfortunately often high, in these types of communities and settings. How do you deal with that in terms of trying to maintain that and that engagement in those partnerships?
It's a lot harder than it used to be. So because we do see such a turnover in staff constantly, and we try to have I don't mean friendly, but we try to be civil and work with our care staff. I know that have a very important job and a very hard job. So, I like to, when I see someone doing a good job, I really, I'm like, gosh, I really, that was great the way you just handled that. I'm going to talk to your leadership. I try to encourage them and create a positive, relationship with them. But it's hard because I know I'll see a staff at one facility, and then the next 2 weeks later go to another facility, and that staff will be at that facility. So here in this area in Boise, per se, I see a lot of changes constantly, and really, it's really hard for us to, affect that. It's up to the leadership and the corporation that owns that company or the owner of that company that is providing those services to be able to, make it a good place to work by maybe money, benefits, and not all smaller places can't really afford to do that. So it's difficult. I'm really not sure how to do that. I just, if they're, because it's just constant, even sometimes with administration, it just seems to be, a couple of months and that administrator's gone. It's hard. We just try to keep, we don't try to berate for any reason, but it's just, we want to make it positive with them and stuff, but we do need to correct them when they're not doing, what is the right thing by the resident.
Right.
And I want to add, what doesn't change is the residents. And so we really build a relationship with the staff and residents, with the staff and leadership and the residents. So that's been my observation. The local ombudsmen have done a great job at doing that. So even like Stephanie said, they move from facility to facility. Oh, I know you were here. So they're familiar with the ombudsman already in the next facility and the program. So that kind of helps to be consistent with the advocacy as well.
Okay, there is a question in here from Dee, and that is, who has bottom line division authority to decide who provides services to the resident, i.e. home health, companies, concierge providers, so on and so forth.
So it should be the resident, but what I see is sometimes in assisted livings, actually, they, in their admission agreement, they can choose to only choose from like home health agencies. They can choose, like have a variety of maybe 4 or 5, because when a home health agency is working in a facility like that, it's the jobs of the facility to oversight that and make sure that they're making sure that the home health agency is doing what it should, and they should be reading their notes and stuff like that. So I have had some times where a resident wanted to use someone they had used in the past, but that wasn't contracted with the facility. So sometimes I've had to advocate for that. Sometimes I've been successful on that, and sometimes not. But bottom line, it's kind of assisted living. The Ralph team will say that it kind of depends on how they write their admission agreement and what's in there. They have an admission agreement, and they should have everything spelled out ahead of time, so that the person looking at that before they sign it and are moving in can read that and decide whether or not that facility is going to work for them.
So, we can go back. So, yeah, this is, yeah, so these are the areas that we cover throughout the state. Like I said, we are contracted with 6 agencies throughout the state. And it's color coded, and you can kind of see our areas and our contact information as well. Next slide. And these are the number of facilities that we provide service to. We have 283 residential assisted living facilities and 10,460 beds, and skilled nursing facilities 82 with 6,202 beds. And then these are ombudsmen from all the different areas. We can, next slide. This is area 3 where Stephanie, she's the program manager. These are our local ombudsmen for this area here. And this is area 4, 5, and 6. Next slide. And that concludes our presentation. Here's my contact in case you want to reach out to me.